नीचे बैठा हो यार। ठीक है, होगा तो जैसा होगा वैसा दिखा।
Good morning. Uh, this introduction was to be given by Dr. Seema, but she has some personal issues, so she couldn't come. So it's my distinct pleasure to welcome Professor Jagat Narula, who is Executive Vice President and Chief Academic Officer, LT Health, UT Health, Houston. And he is a K. Lance Gould Distinguished University Chair in Coronary Pathophysiology. And this is from his official card, but on a personal note, Professor Jagat Narula is known to me for a very long time as a very dear colleague and friend, and also one of those who has changed the landscape for functional MRIs, the functions of the heart, and also has done tremendous work in the perspectives related to coronary and cardiovascular health. He came for another program to India, but I requested Professor Narula to give us a talk. And the talk is, can we eliminate coronary disease? And all of us want. You all want to eliminate coronary heart disease? All right. So here you will listen from the legend. Welcome, Professor Jagat Narula, with a big round of applause. And we also welcome Dr. Chopra.
Thank you, Dr. Sareen. Truly an honor to be speaking where you lead the field. As I was saying day before yesterday during the Sitaram Jaipuria, it was the symposium that they had where they were giving the healthcare and medical care awards for the elites in the country. And I was saying that I'm truly honored that Dr. Sareen was chairing the jury there and was responsible for picking up the stalwarts. And so I have followed Dr. Sareen since 1973 when I started my medical school. Dr. Sareen was 4 years senior to me in Jaipur Medical College. And as I say that we always idolized him. And the most important part that I started following him was looking at his college magazine. We used to call it Sanjeevani. Mridul will remember it, Sanjeevani. And his magazine was the best magazine that was edited ever for the almost 25 years of the history of medical college at that time. And so then I became the editor about 4 years after him. And so that was an inspiration. And then followed him all along. He came to All India Institute after that. I went to All India Institute, and I said that the only regret was that I went to cardiology and not followed him in gastroenterology, not to know that the paths will start to cross at some point in time. And back in 2012, I think, when you had almost just started here, when I had come here for the Cardiology Society of India, Dr. Chopra, if you remember, those were the days you were becoming the president of Cardiology Society of India. And he told me that I should start working on the interaction of or intersection of the liver and cardiology. I think I was naive at that point in time, and I wish I was mature. I was mature enough to have recognized the importance of the metabolic disorders at that point in time. And if so, I probably would have been 10 years ahead of the curve. And I will try and show a few of those slides in the during the discussion today. So, can we eliminate coronary disease in our lifetime? And we know all about it now. But knowing is not enough. We must apply, and willing is not enough. We must do. And that is the way I would like to try and present my case. And I apologize, Dr. Sareen, that you might have to bear with me because few of the slides happen to be the same what you might have seen a couple of days ago, because topic was essentially similar on that day as well. So I started with the medical history of Bill Clinton. And it always helps if you start to look at some of these celebrities who have suffered from something what you almost see in your daily practice. And HK would agree that 55 to 60% of times, your first manifestation of the coronary artery disease is the acute coronary event. They have not had chest pain. They have not had any other indications, whether it is subjective or objective, about the presence of coronary disease. So, 1992, he was just assuming the office, and he, as all the presidents and all, they are subjected to thorough medical examination before they take over for obvious reasons. And as you can see here, that almost everything is normal, except that he was BMI was 29, but BMI, as you know, could be fallacious, and very muscular guy, athletic guy. And when he was subjected to the treadmill test, he had reached the stage 5 on the Bruce protocol with the 91% of the maximum targeted heart rate with no electrocardiographic changes. Myocardial perfusion was normal. And once the stress test is normal, as I always say, that it looks like as if you have been given a certificate of immortality. Like if your stress test is normal, you are stage 5, likelihood of having an event is very low. So, with that kind of an assurance, he starts his presidency. And every single year thereafter, they have an annual examination that used to happen at the Walter Reed Hospital. And every single year, he will go beyond stage 5 of the Bruce, and used to jog every day morning many a times with Alan Gore in the morning. And 1999, these are those impeachment days when his cholesterol profile was done. And as you can see, that the total cholesterol is 196 and LDL of 130 used to be considered normal in those days. We used to consider 130 of LDL normal, not so anymore. And as you can see, day before yesterday, the guidelines, dyslipidemia guidelines, came out from ACC/AHA, and you would see the numbers are much, much, much lower than what we used to consider normal at that time. And I always say that this normal is not normal. What we say normal is the usual value of a population that is at a risk, high risk of dying from a vascular disease. That is what the Framingham Heart Study was. When the Framingham study was done or started back in late 50s and early 60s, as you very well know, that there was a significant amount of mortality and morbidity. The presidents of the country were dying of heart attacks. And that is the reason that the Framingham was started. And the numbers that were identified of the general population, which was dying of the vascular disease, they were considered to be the normal numbers. So they are not normal numbers, they were the usual numbers. So 130 for those days, but well, it was normal for the standard practices. 2001, he's leaving his office, and total cholesterol and LDL both have jumped about 40 points. After that, we do not know whether he was on statins, he was not on statins, any lipid lowering or anything being done. Until now, whatever I have told you, that has all been taken from yahoo.com. There is no HIPAA violation. There is no confidentiality breach here. But thereafter, when he was not the president or the sitting president, there is no information online until 2004, which is just about 3 years later, that he had an STEMI and required an emergency quadruple bypass surgery. So a person in whom we did not know that he has the coronary artery disease and he develops heart attack, requires quadruple bypass surgery. Another one, Tim Russert. And you remember Tim Russert. Tim Russert was very famous journalist for the NBC, Washington bureau chief, and who is famous for his very eloquent interviews of major political leaders. And here he is interviewing the president for that time, the junior Bush, and that was the time in the studio when he died suddenly. He basically, we knew that he has a heart disease. Why? Because he had coronary artery calcium, that we knew that it was in 1998 that he had coronary artery calcium score of 210, significantly high for that age. He was overweight. He had waist circumference, which you all know better than I. What does it mean? The impaired glucose tolerance, high blood pressure, high triglycerides, whatever you want to call it as, or whatever way you want to name it as. He was on antihypertensives and he was on statins also. I don't know what the dose of statins he was on, whether it was enough or not, whether it had brought down the LDL down to the level that I would propose you to have. But he, in April of 2008, we knew he has coronary artery disease. He undergoes treadmill test, which was negative. So you have calcium, fine. You undergo treadmill test, which is normal. So you know that coronary artery disease is not stenotic enough to cause any problem, and we let them go. That's what the practice is, right? So he was suggested that he should be doing exercise daily, he should lose weight. He never reported chest pain to warrant any invasive test. But then, after the interview, he dies suddenly within 6 weeks' time when he's doing the interview of President Bush. That day, he died suddenly. So, in first person, we did not know that he has coronary disease. In the second person, we know that he has coronary artery disease. Both have heart attacks. So, what are we missing here? So, I presented this slide 2 days ago also. This is the study which just came out about 6 weeks ago. And I had started this study when I was back in New York at Mount Sinai. And we were just looking at, and it's something very simple. We all know, as I said, that Dr. Chopra would agree with me that most of the people who present with acute MIs, we basically do not suspect that they would have a heart attack. So I had just started it, very simple study that everybody who comes to our CCU and he has or she has acute myocardial infarction, we'll just figure out as to whether they have had chest pain earlier or not. Something extremely simple, but has not been methodically done. So symptoms is about 500, simple 500 patients coming to one single center. Symptoms are not the warning sign. So why do I say that? Because 53% of them developed symptoms only on the day of the acute event. So half of the people have never had the chest pain. Some of them must have had in 24 hours earlier. Somebody must have had it 48 hours earlier, what you call as a stuttering type of a situation. And then silent atherosclerosis is the true killer here. Most first-time myocardial infarction patients are asymptomatic. So it is a complete mismatch between the guideline tools and the real disease. The message becomes clear. And trust me that this was such a simple study that we did, very ordinary, very clinical, day-to-day importance study, which has not been otherwise systematically presented. Trust me, there was 200 television stations who got in touch with us and they wanted to interview us on that day. So the first author was Dr. Amadi. He really did a fabulous job of going out and discussing the study widely. So what was the conclusion or the summary was that we need to detect disease, just not predict it. That the risk calculators are population tools, symptoms and the stress tests are the late markers, and none of them identify early coronary artery disease in an individual. So we need to do more. And as I always say, that we need to find Waldos. Where are they in this particular crowd? Can we really identify them? So they had those striped pajamas and striped shirts and things like that. Can we really figure them out from a distance as to who is the one who is going to develop a heart attack? So as I always say that the onus is on us to find out who will live without events and who will die of preventable events and when. So the basis of the disease is something which was first presented by Dr. Michael Davies in he was a fabulous pathologist in London. So he had started doing the autopsy studies in the people who have had the acute event. And as you can see here, that the one on the top in the middle panel, that you will see that there is a person who has died of acute myocardial infarction. And what are we seeing in this? If you look at the area here, there is a significantly large necrotic core which must have had a significant deposit of the lipid or the lipid and the inflammatory cells, the so-called foam cells that the macrophages who consume the LDL, which insudates into the area, and this is thrombogenic. Once it is covered by a very thin fibrous cap and that cap ruptures, this thrombogenic necrotic core, when it gets exposed to the blood in the lumen, it creates a thrombus there, which occludes the lumen and causes the acute myocardial infarction and or death or whatever else the complications are. On the other hand, if you have the cap, which is significantly thick, as you can see here in the left lower panel, even though there is a large necrotic core in this area, there's a significant deposition of the fat here also. But since the cap is very thick, this is not going to give way. It is not going to occlude the lumen. And even if it is occluded just because of stenosis, it will not result in an acute myocardial infarction. So basically, the two plaques which are distinctly different here, this can give rise to the chest pain, but is not going to cause the acute MI. This is the one, regardless whether it is stenotic or not, it is going to give rise to significant event in this particular case. Now, let me show the same thing to you in histological display here, that there is a patient here on the left hand side who died suddenly, and as you can see here that this is a huge necrotic core here. It was full of cholesterol crystals, necrotic core and all, and you'll see that it has a thin, very thin fibrous cap here, which is inflamed because of the cells of the macrophage monocyte origin. At the thinnest point, it gives way, and that can happen during exercise. It can happen during the stress. It can happen otherwise, that whenever there is a hemodynamic perturbation, there will be a cap which can rupture, and with that rupture, the necrotic core is exposed to the lumen, and there would be an event. Now, on the right upper panel here in the left half, you will see that there is another necrotic core here, another patient with a thin fibrous cap ruptured at this particular site, must have led to the formation of a thrombus, which has just fallen off when we are sectioning it. And then the third one on the right lower panel, you will see that there is a huge necrotic core again. You can see the cholesterol crystals here. And then there is a very thin fibrous cap ruptured at this site, resulted in a necrotic, thrombus, which has completely occluded the lumen in this particular case. Now, if I tell you that we have same histological signatures as this, but the fibrous cap has not yet ruptured, that means the event has not occurred. So, same huge necrotic core, very thin fibrous cap, inflamed, same thing on the right upper hand and right lower hand. Now, why have I shown three pictures here? The reason being that I've tried to show that the histological signatures are uniformly there when we call these plaques as the high risk plaques, or plaques which are vulnerable to rupture. So they all all large plaques. They are all huge necrotic cores. They all have very thin fibrous caps. These caps are inflamed. The lumen may be variably affected in these cases. For example, in this particular case, the lumen is not affected at all. In this case, the lumen is critically occluded. And in this case, lumen is modestly occluded. So this and this is not going to cause any chest pain. So patient won't come to you. Even if you did the stress test or treadmill test, basically you are not going to find ischemia in this particular case. Only this is the person, if he had come to you before he died, you would have recognized him by doing a stress test or even a coronary angiography or whatever else you wanted to do in this particular case. He may have complained of chest pain as well. So now the question is that this is a vulnerable plaque or so-called high-risk plaque. Why is it that there can be so much of a deposition of the lipids or cholesterol here, yet there is no chest pain and no luminal occlusion here? What is the reason? The reason is that when the fat starts to deposit in a plaque or in the vessel wall, first there is an expansion of the wall outwards. Since it is lipidic, it is fluidic. It basically pushes the wall outside. It doesn't constrict on the lumen. The constriction on the lumen will occur when there is more smooth muscle cells or there is more fibrosis or anything else. But as far as the lipid is concerned, it always pushes the wall outwards. And the fat keeps on collecting in the vessel wall until there is at least 40 to 60% of the total vessel area is occupied by the lipid. Only after that, it cannot go any further out. Something what we call as Glagau's phenomenon, or the positive remodeling, that the external elastic lamina of the vessel goes or stretches out so much that it cannot go any further. And after that, it starts to impinge on the lumen with vengeance. It goes fast after it has reached the 40 to 60% of the total vessel wall area. So this is called positive remodeling, or expensive or expensile remodeling, which I often show by comparing any one of the models here, compare them with somebody like George Orson Welles, or who is he, Nitin Mukesh, or whosoever is big here, right? So whenever you have a fatty collection, there is an expansion outwards. Whenever there is no fat deposition, there is always a negative remodeling or constrictive remodeling in this particular case, as it has been shown in the left-hand panel, which is something which was shown by Seymour Glagau from University of Chicago on autopsies, later on proven by the intravascular ultrasound, and now we have shown the same thing by the coronary CT angiographies as well, that unless you have occupied 40% of the total vascular area, the plaque keeps on pushing the vessel wall outwards. So the positive remodeling and negative remodeling in this particular case. So I started doing the CT angiographies back in 2003, when we had received our first 64 slice CT scanner as a gift from Toshiba, and also got a huge grant from them to do about 3,000 cases with the CT angiography and follow them over a period of time, because we were showing the vulnerable plaque by pathology, and the expectation was that we would be able to identify them by a non-invasive imaging technology or strategy. At that time, when we started to present the results in 2005, basically people were very skeptic about it. They said, oh, you'll never be able to identify the vessel wall in a beating heart and things like that. And people used to laugh at us, to the extent that once when I was giving a keynote at the TCT, I was told that I dream a lot and I am on a slippery floor. So those were the things that were told to me at that point in time. But what we found in the patient was, first we compared the intravascular ultrasound with the CT angiography, demonstrated that we can identify just by looking at simple Hounsfield units on the CT angiogram, we can correlate the pathology and on the non-invasive imaging. Then the next part was that we looked at the people who had who had presented with the acute coronary event, and we did the CT angiograms in them and demonstrated the imaging characteristics or non-invasive imaging characteristics of people who present with the acute coronary syndromes. And later on, we started to follow those who had such plaques, follow them for 2 years first, and then followed them up to 10 years, large number of subjects. And as you can see here, that the people who presented with the acute event, here it is the NSTEMI. In this particular case, you will clearly see that there is about 50% stenosis in this case, and there is a positive remodeling. If you remember Nitin Mukesh here, does it look like one? And then you will also see that there is a less than 30 Hounsfield unit densities here, and there's a huge necrotic core extending right from the bottom of the plaque to the top of the plaque here, as shown by the red arrows in this particular case. And there was another skepticism that was shown by the journals. At that time, NEJM rejected it, saying that it is impossible. And then we went to Jack, and Jack also said that you can't call these plaques as vulnerable plaque or soft plaques because the event has already occurred, and you should give some kind of a non-specific name to this particular plaque. So I didn't know what to call it. I can't call it soft plaque. I cannot call it high-risk plaque. I cannot call it plaque vulnerable to rupture. So I thought, very simple thing. There are two features here, yellow feature and a red feature. Just literally call it as a two-feature positive plaque. right? I mean, it can't go more non-specific than that. And there is a reason that I'm saying that, because all the youngsters that are sitting here, you just need to go forward with what you think is right. As long as you are truthful, as long your observations are right, you should present them as it is. Don't care whether they buy into your concept or they don't buy into your concept. So we said these are the two feature positive plaque. And then you look at the plaques which do not rupture. These are called the two feature negative plaques. If you remember Harnaaz Sandhu here. Right. So there's a negative remodeling in this case, even though the 99% occlusion of the lumen is there. Now, not only that the concept got bought into, now all the plaques which are vulnerable plaque, they are all known as two feature positive plaques or two feature negative plaques, which are the stable plaques. So basically it has now become a lingo that, so what we found was that those who had two feature positive plaques, 1,000 patients, at least 2 years of follow-up, you will see that there was 22.5% likelihood of having an event over the next 2 years, as compared to less than 0.5% in the two feature negative plaques, giving me a hazard ratio of approximately 45:1. And we thought we have won the field. We have explained what really happens, and that now we'll be able to diagnose every single person who is going to have a problem. So we not only that, we have now gone too far out in these cases that we have now gone with the machine learning algorithms here, that we look at multiple features at a given time. We've compared them with the intravascular ultrasound and all to identify those features which are the most important features. And as you can see that there are now 4 features that we consider upon the machine learning methods which really contribute to the plaque event. And those are the total degree of stenosis. Yes, that is important, because if you want to have the hemodynamic perturbances, then the number of low attenuation plaques and the positive remodeling, as I talked about, then the total plaque burden. So how much is the volume or the plaque burden at the site? And lastly, the delta FFR. Now, what is the delta FFR? That is the fractional flow reserve, the drop of the pressure from above the plaque to below the plaque. So at the plaque, the total amount of the physiologic significance of that lesion. Because if you want to break that fibrous cap or thin fibrous cap, you really need to have a significant pressure drop across the lesion. So by looking at these 4, now we have created the algorithms. We can tell you that if the total amount of the lipid lowering therapy is not changed, what will be the trajectory of this plaque to progress over a period of time, and when is this plaque going to rupture? So we are able to now predict. And the other plaque here, as you would see, that plaque is not increasing in size, and we know that this plaque is likely to be a stable plaque. Now, once we were rejoicing or celebrating our success, the nature brought us back down, because nature is way more complicated than we think. Sometimes depending upon the talk, I say nature is very simple, it is not complicated. And sometimes I say it is too complicated. In this particular case, you will see that there are now 3,000 people and we have a 10-year follow-up here. And this study was an eye-opener. We, after having done and looked at the baseline coronary CT angiogram, we realized that the high-risk plaque is a high-risk plaque. So here it is in the red color that you are seeing that there is a high-risk plaque here. And this high-risk plaque compared to the non-high-risk plaque, there is a 10-fold higher likelihood of having an event over the 10 years, right? So if you remember at 2 years, there were no events. Essentially, these plaques appeared pretty benign to us, suggesting thereby that if I repeated the CT angiogram every 2 years, I probably would be able to be way more informed rather than just doing it once in your lifetime. But how many people can you do the CT angiogram and how many times in their life? Would I be repeating every single time? If I had a luxury, yes. If I did not have any side effects, absolutely yes. But radiations and so many other things, cost factor, the practicality and so many things, would I really be able to do that? And as you would see here, that non-high risk plaques now do not seem that benign. Why? Because some of them would also start to become high risk plaques over a period of time. Regardless, non-high risk plaques have 10 times lower likelihood of having an event as compared to the high risk plaque. But there is a big catch here. Whenever I do a CT angiogram, about 90% of the plaques are non-high risk plaques, and about 10% of the plaques are high risk plaques. If it is so, even if there is a 10-fold higher likelihood of having an event with a high risk plaque, but they are 1/10 in number, at the end of 10 years, if there are 100 episodes which have occurred, 50 of them occur because of the non-high risk plaques, or 50 of them occur because of the high risk plaques. So, who are the ones who really develop the events? And we found out that those which progress, whether they started as a high risk plaque or they started as a non-high risk plaques, if they progressed in size over a period of time, yes, they resulted in an event. So there were about 500 of the patients where we had the serial angiograms done at a difference of, or at an interval of 1 year, and we found that those who progressed, they resulted in an event. Now, a high risk plaque that does not progress, that also would not cause an event, leading us to say that the most important characteristic of a plaque which is likely to rupture is the plaque progression. Right? So the plaque that progresses over a period of time, that results in an event. Now, what do we do clinically? What is our practical implication of these things? And it is something very simple, that we have to be vigilant about the risk factors. And as I was discussing with Dr. Sareen on that day, that most important thing which is missing from there is your metabolic dysfunction here. We don't have the MAS LDs and other things in there, which probably now need to be done. So, if I look at the risk factor profile, and there are lots of changes which have now happened in this risk factor profile. And this was the INTERHEART study done by Dr. Salim Yusuf. Proud that he is also an Indian, and has done studies which have, like, the across the continents, 5 continents, and now approximately 70 plus centers which contribute to his data. This was one of the earliest studies from him, so-called INTERHEART study, 52 countries, 27,000 subjects. And Framingham had talked to us about some non-modifiable risk factors, some modifiable risk factors. Non-modifiable were age, genetics, and sex, while the modifiable were lipids, so cholesterol, cigarette smoking, hypertension, and diabetes. Those were the 4 which were given in those days. Gradually, the spectrum started to expand, and now it has expanded significantly more. We just completed our AI for healthy cities in multiple cities in the world, most important being New York, Singapore, Helsinki, Lisbon, and some of the others, where we have now the data which has been done with the Microsoft and the Novartis Foundation, that we have now more risk factors here, and they eventually are all converging through the same risk factors. For example, in New York, you'll be surprised if I tell you the most important risk factor was the low educational standard. Now, why does it make sense? Because they have no knowledge about the importance of exercise or food or air pollution or other things there. The second was the lack of broadband internet. So they didn't have the access to the internet. How does that make a difference? They are socially isolated. Where do they end up? If they don't have if they are not sitting and not looking at it, although the other day we were discussing that the screen time is a problem and things like that. Here comes a situation where you don't have a screen time and these people are feeling isolated. They don't have the family structures the way we have here. They are isolated there. Where do they end up? McDonald's, right? So, and then they're gaining weight. There are so many other things which are happening. So there are multiple things which are now being identified. Your sedentary work habits, desk jobs, how far are you from the work? If you are long distance away from the work, it is causing more problems there. So there are so many things which have now come up, but they are all working through the same risk factors. So let's just focus on lipids here. So the cholesterol here, as you'll see, that the population attributable risk is approximately 50% in this particular case. If I have access to all 9 risk factors, whether protective or causative, there is more than 90% of the disease that is explained here, because the remaining disease will be explained by not having a risk factor internet, or not having the food stamps and things like that and whatnot. Well, when we talk about the lipids, as you will see here from the Interheart study, that these are the deciles of the increase in LDL cholesterol, although expressed here with the apolipoproteins, because these were not done in fasting, and the apolipoproteins are not affected when you are doing them in a non-fasting state, so as to make it more convenient for data collection. You will see that as the deciles are increasing, there is an increased risk of having a heart attack in these cases. So again, 27,000 subjects from 52 countries. And as you can see here, the outcomes remain the same, whichever country you are in. So whether you are in North America, South America, Europe, or Asia, wherever you are, essentially the odds ratio remains the same when you are hypercholesterolemic. Right? Now, some other risk factors. And I started to look at it because Dr. Sareen wanted me to specifically come to the risk factors with the MAS LD and the coronary artery disease. So when we look at various risk factors, whether it is tobacco use, it's diabetes, it's the LDL, or it is hypertension, you'll see that the non-calcified plaque. Now, non-calcified plaque, I don't want to go into too many details of that, but non-calcified plaque, which is likely to be more likely to be the vulnerable plaque here, you'll see that there was a significant increase in the non-calcified plaque when there were risk factors, and the high risk features are also significantly more when the patients were or the subjects were consuming tobacco in whatever way, or they had diabetes, or they, with every milligram increase in the LDL-C, you'll see that there's a significant increase in the likelihood of having a high risk plaque. Similarly, for the age also, with every 1 year, there's a significant increase in likelihood of having an event. So this was 2012, and he wanted me to start working on the MAS LD. At that time, it used to be called something else, not the MAS LD. But my apologies, Dr. Sareen, for not having done that. So, as I said, that why is it that every time opportunity knocked on my door, I was in the bathroom? So anyways, so when we start to look at the MAS LD and the CT angiography here, you'll see that now there are about 4 or 5 studies that have been shown, and they have really made an impact. One of them having won the Young Investigator Award at the SCCT, the Society of Cardiovascular CT conference. And the MASLD patients have increased prevalence of high-risk plaques with an odds ratio of more than 2, with specifically higher rates of positive remodeling, 3 times higher remodeled plaques. What do they tell you? They tell you that there's more lipid deposition in those plaques. Then the MAS LD, after adjusting for the standard multiple risk factors, are associated with non-calcified plaque, or so-called more high-risk plaques. Again, close to about 2 times higher likelihood of having that high-risk plaques, which were present in about 60% compared to 20%. So almost 3 times more, and the odds ratio of more than 2 again. They had more low attenuation plaques. That is, they had more lipid deposited in them, at least 2-fold more. There was more positive remodeling, again, significantly more, and there was more spotty calcification. I don't want to go there again. And then, if you really start looking at your parameters, which you understand better than I do, that the SAFE estimator was strongly associated with all plaque types and obstructive coronary artery disease as well. And these are the studies which demonstrate, and this is a meta-analysis of these which demonstrate that they are the mass LD was associated with any type of coronary plaque, non-calcified type of coronary plaque, as well as the obstructive coronary artery disease. So now let's get and let's make it a little interesting and not make it more sermon like here. So let us go for some kind of an evolutionary support here, that was the disease ever did it ever exist in earlier times, because we all now know that it is a disease of modernity, and that the disease occurs because we are now more sedentary, we consume a different kind of a food, we don't we smoke and things like that. So does that mean that the disease did not occur in the earlier times? So we hypothesize, and it's a very simple hypothesis which just got developed when we were visiting a museum of antiquity in Cairo. And we're looking at the mummies and discussed whether there is any possibility that if I started to image mummies and started to look at the calcium in their vessels, we will be able to identify whether the atherosclerosis existed there or not. There are some reports of atherosclerosis by an English pathologist, so-called Rufus, who had given some idea that atherosclerosis probably did exist in those times. But we never believed that with that kind of a pristine lifestyle in those days, we would have had the coronary disease. So we started to go and do the images, and now we have approximately 200 Egyptian mummies that we have imaged, be it in Cairo or in Turin or Berlin. So looking at them, we thought that they may not have had coronary artery disease. That was the hypothesis that we started with. But this is a 3,500-year-old mummy. And this was one of the high priests and a scribe to the pharaohs at that time. And as you can see here, that when we looked at the coronary calcium scan, you will see that the right coronary artery here, left anterior descending coronary vessel here, you have the aorto-iliac bifurcation in this particular case, which is heavily calcified. So finding the unexpected here, we never believed that we will see that. But 34% of them had some kind of a vascular calcification, completely threw us off. On one hand, we were surprised, more or less bewildered. On the other hand, we were happy that, you know what, we can eat anything. We don't need to exercise. We can smoke. We can do anything. If these people had it, that means we are doomed, because these folks who lived so much better than us, basically, if they had disease, we are going to have a disease. So it's okay. I mean, it is destined. We will have to, if we have to suffer, we have to suffer, right? But when we talk to the mummy scientists there, most importantly, Dr. Zahi Hawass, who is a very famous mummy scientist, had been a minister of antiquity in Hosni Mubarak's regime and all. So talk to him and figure it out that that these people now were no more hunter-gatherers. They had started living in a society. They were all high-flying folks because they were carried in palanquins. They are all Egyptian elites. And they used to have free-flowing food. They had started animal husbandry. So they had access to beef, goat, wild fowls, whatever else. And they were cultivating. They had significant amount of, I'm fine. They had significant amount of grain and whatnot, and they will make bread, cakes, wine, everything. What is it that we have today and they did not have at that time? So soon realized that we were dealing with a wrong population. So we needed to find a better population. Ended up in Peru. In Peru and in Chile, 5,000 years old to about 1,000. These are the Inca culture. And in that, you basically would see that these are all along the Andes mountain series. There are multiple mummies, but these are all naturally mummified, unlike Egyptian, where they were mummified and only elites were able to do. Here, once the person is dead, they will put him into the knee elbow position, wrap them in the rags, bury them underground. There is so much of a salt in the soil that some of them, and there is so much of dryness that some of them would get mummified. And so thousands and thousands of mummy bundles are there. We have imaged about 200 of them. And the reason they used to do them in the knee elbow position was because you have to go back to the afterward in the same position you came to this world in. Right, so that's kind of a culture or belief in those areas, and as you'll see that some of those mummies which are in the rags here, one of the very well preserved mummies here, they call her a shy face mummy, which is very famous. It is in one of the museums there, and we thought that these are the right kind of people because they are all manual laborers. They exercise a lot. They are farmers. They go up and down the mountains. 50% of them are vegetarians. 50% of them consume alpaca or llamas, which is a very lean meat. It's absolutely white meat, quite like cardboard. Essentially, you can't even eat it. It's so lean. And so we thought this is the right kind of, or some of them consume the sea mammals, which are also a much healthier meat as compared to the others. So we thought we have the right population. But again, what we find is that about 24% of them had an evidence of large vessel calcification, suggesting again that there's something going on in here. And then we figured out that we did some of the autopsies, and we found out that most of them who had atherosclerosis had black lungs also. And it was in those where you don't want to see atherosclerosis, more in women, more in young women. So we were like completely confused. Now, where can the black lung come from? Obviously, you are kind of cooking or you are getting exposed to smoke. There was no cigarette smoking at that time, and obviously that will not give rise to black lungs anyways. So we ended up going to the places where these mummies came from. So they used to live in the low lying huts, and they used to cook inside, and they will be exposed to smoke. So women had more atherosclerosis. We went ahead and did the multiple other mummies at multiple other places. We ended up in the southwest of US, Nevada, Colorado, New Mexico, and Utah, and other places. And there also the same thing, significantly high amount of the calcification, as you can see here. Even the aortic calcification, you can see these are the people who lived in the pit holes or cliff holes. And as you can see here that they have the fire that they would light here. There is only one hole from where in the ceiling from where the smoke will leave. So they are exposed to the smoke. Went to Greenland and did some of the this is in the Aleutian Island in near Alaska in the Bering Strait. As you will see that same thing, they are lighting the fire here, and whole family would crowd around there just to have for the heat as well as for cooking here, even though they had much better lifestyle in this particular case. We ended up in Greenland. These are the Greenland Inuits, and the same thing, they will live in the igloos and they'll light fire here for heat in these cases. And imagine today in our country, although it is now much better with the Ujjwala Yojana and other things in our country, but then most of the low and middle income countries, the women are exposed to smoke because of the indoor cooking. Not only that, even the children are exposed to so much of smoke within the homes, and obviously this indoor pollution is causing a lot of damage. And I thank Annie Griffiths. She is the lead photographer of National Geographic. She has gone to about 100 plus countries where she has taken the pictures in the kitchens. And we really want to, from the World Art Federation, we really want to raise awareness about the indoor pollution. We even imaged Udzi, the Iceman, 5,300 years old, and he had the iliac and femoral calcifications as well as some carotid calcification. And you know what was there in his stomach? lot of, he was very, very fond of eating goat bacon. So he used to get the ibex, or so-called mountain goat, that he used to hunt for and consume. So, realizing that we were not able to find anywhere, we ended up, and these are last few slides where I would like to really push you to think today. And that is that when we were unable to find any ancient culture that does not have the heart disease, and here this is our Horus team, led by Greg Thomas from University of California, Irvine, Alam from Egypt, Professor Magdi Yaqub, whom you all know very well, and our entire team of people who we have been going all around. And so then we were told that there is a tribe in Bolivia where these people do not, they live very long. They live to 100. We knew about all these blue zones, which you have about 7 blue zones on various islands in the world, where people are genetically privileged or genetically endowed, in the sense that they, for some reason, they don't develop coronary disease, whether they have more ApoA1, for example, ApoA1 Milano, or they have more PCSK9 loss of function, or they have got some other reasons why they eat better and they live for 100 years, right? But then there are certain places where people still live longer, and we wanted to look at them. And so this is one of the tribes, which is called the Chimane tribe. And this is the Chimane Health and Lifestyle Project. Which was led by Hilly Kaplan from University of New Mexico. So we worked with him. And as you can see that this is the river, Manuki River in Bolivia. It is a tributary to Amazon. And so we went there, and these are the people who live very long. And what do they eat? As you can see here, that they eat the piranha fish. They actually use the bow and arrow to do that. They eat jaguars, monkeys, pigs, and there's some wild fruit here. And here I would show you that this is a couple which had come for the cataract surgery. 99 years old woman, 85 years old husband. These people, if they don't die by the age of 5, they'll live to 100. So either they're gone by infections, otherwise they will live to 100. Here I'm seeing them for their cataract surgeries and whatnot. What do? They live in open huts. There is no pollution. They eat once a day. So they will hunt for these animals, and then they will prepare stew, and they will eat once a day. And for that, they walk the whole day because they have to hunt, and they walk almost 20,000 steps a day. So we did about 750 CT coronary scans in them. And then we did about 3,500 carotid ultrasounds in them. And as you can see here in the middle panel, in this particular case, that they have no coronary artery calcium. Very small number, less than 8% of them by the age of 80 reach hardly about 100 coronary artery calcium, compared to all the other races across the world. Look at the Americans, distinct honor of having so much of coronary artery calcium. By 80 years of age, they've got about 1,600 coronary artery calcium score here, as compared to the almost close to 0 for the Chimane population, be it men or be it women. On the other hand, here I'll tell you other risk factors as well. LDL of less than 70, blood pressure of 115, systolic blood sugar of less than 80, BMI of 24, 15 to 20,000 steps a day, no pollution, no coronary artery calcium. And if they don't have coronary artery calcium, why can't I not have the same situation? And I often push people to think that all the animals in the world have total of 100 cholesterol, total cholesterol. And there is proud animal who has 200 total cholesterol, and that is human. All the animals have HDL, which is more than LDL, because HDL, like us, every animal has 45, but their LDL is 25. They are all born with 25, and they remain 25. Not only that, even we are born with 25. But you know what? I don't know what do we do in the first year, second year, third year of our life that it becomes 130. What do we do? So we started to look at it, and again, liver plays a role here. And that is that when we start to consume sugar, which we start consuming in the very first year of our life. Most important being the formula that we take. There is no formula in the world except a few here and there which are not popular. They are full of corn syrup, corn solid, and sugar, table sugar. So that is what we start feeding our children with. And what happens is that we hypothesized, and now we are proving that hypothesis significantly, that the sugar with the insulin increase through the mTOR, AKT, and PI3 kinase pathway produces more and more of PCSK9 that goes and binds to the LDL receptor, removes the LDL receptor. And also, these formulas have less cholesterol than what the mother's milk has. The human mother's milk has maximum amount of cholesterol. And that is necessary for maturation of your HMG-CoA enzyme reductase pathway. On the other hand, when we make the formula, we say, oh, we made it healthy by reducing the cholesterol. You didn't make it healthy. You made it worse. And then you added the sugar on top of it. Right? So that creates more of a problem. So we wanted to do a study there, and we wanted to randomize our patients. But I was not allowed because there was nobody to indemnify. Something happens 30 years down the lane or 40 years down the lane, and a person develops ADHD or a person develops depression. Who is going to deal with their legal implications? So my study was denied. So we had to wait for looking for something where there has been a random exposure to sugar-rich diet early in life with outcomes measured decades later. Can we get some kind of a random exposure? So we lucked out here. UK Biobank study. UK Biobank study started long back, as you know. And so we now had this access to about 28,000 subjects here. So 23rd of September 1953, after the few years after the World War II had ended, the sugar rationing was ended in United Kingdom. So what we did was that we look at 23rd September 1953, 1,000 days before and 1,000 days after. All the children that were born at that time, we compared them. One exposed to sugar, one not exposed to sugar, both in utero as well as first 2 years of life, or in utero plus 2 years of life after the sugar rationing and ended. Gives us a simple, straightforward, random exposure to sugar, and we have an availability of a 40 years follow-up now, because that was 1953. So 40 years later, in the 1993, you have all the data for them. Right? So you look at their cholesterol, you look at how many of them have developed diabetes, how many of them have developed, what do you see? First important thing that you will see that in 1953, the total consumption of sugar has increased at least twofold overnight. All other things remain the same, your protein, your fats, your produce, fruits, vegetables, they remain the same. But the sugar has just increased, right? You have like now no limitation to the cakes and pastries and all those things in England at that point in time. Look at the diabetes on the left-hand panel and hypertension on the right-hand panel. 12% increase, 12% reduced risk if people were born in the sugar rationed time, and there was a delay in onset in those people. So similarly for the hypertension, also significantly greater amount of people who had hypertension. Not only that, there was a jump in the total cholesterol level here, as you can see in this particular case. Also, the inflammation is significantly more in this particular case. More cardiovascular disease, more myocardial infarction, more mortality, more strokes. So, very simply, more the cholesterol, more you are exposed, longer in life, you will have more cardiovascular disease. So it is the length of exposure to cholesterol that is causing the problem in this particular case. And as you can see here, that if the level of the cholesterol is changing, earlier is the atherosclerotic cardiovascular disease threshold occurring. What is the threshold? When there is more than 1% likelihood of having an MI. That is the atherosclerotic threshold. So it comes earlier if you have the greater amount of LDL. Not only that, if you start to reduce the cholesterol, something similar happens. And this is something which was started by Dean Ornish back in 1992, the Lancet, beautiful Lancet paper done with Swami Sachidanand in Colorado, in where they had taken them for meditation and yoga and only vegetarian diet and whatnot, showed that their LDL improved and their coronary artery occlusion decreased in those particular cases. And now we know that if you bring our LDL down to 70, there will be a no progression of the plaque. But if I want a regression of a plaque, I have to go below to about 40, 30, or even lower. If you look at the primary prevention, all the statin studies, if I extrapolate the line and I want a zero level of the cardiovascular event, I'll have to bring it down to 55 LDL, exactly the number which has now been shown in the dyslipidemia guidelines day before yesterday, although that is more for a secondary prevention than primary prevention. For secondary prevention, if I want zero MACE or major adverse cardiac events, I've got to come to 30 or lower. So in my last slide, I would like to bring you the concept which Dr. Braunwald wants to promote. There is the new mRNA therapeutics which have become available now. Something what is called inclisiran. It is a small inhibitor of RNA which goes and kills the PCSK9 at the mRNA level, suggesting thereby that there will be no PCSK9 produced. And if we believed that the PCSK9 was all epigenetic, it will be a most physiologic way of maintaining the LDL level to where we were born. So he suggests that at the age of 35, he's not doing it earlier. I may want to do it even earlier. He says that at the age of 35, if I started to give one inclisiran a year, although the proposed is 2 times a year, but he says just take one inclisiran a year, flu shot on the left-hand side and the inclisiran on the right-hand side. Basically, you will be able to push development of the atherosclerotic cardiovascular threshold to 100 years. So you live to 100 without having a heart attack. And that is always I call like, can we bend it like a Beckham? Thank you.
It's amazing journey, and thank you, Professor Nirula. Are there any comments or questions or suggestions to Professor Nirula? It really makes us feel we can and we should. Yeah.
Thank you very much, Jagat. I think it was a brilliant talk, brainstorming, mind stimulating. I think you use a very right word when you're speaking. Dream, but dream rightly. I think whatever you did is a part of your dream. And I learned that vulnerable plaque, you are the pioneers.
Yeah.
And I personally believe that vulnerable plaque with vulnerable age, with vulnerable hemodynamics, and vulnerable lifestyle are the main factors, including the vulnerable environment, which you mentioned, the pollution. I think it's a multiplicity of factors. Besides the risk factors like hypertension and diabetes, and most importantly, stress. You quoted Dean Ornish data, which is a very, very important data. And you also quoted that if a baby is born, the baby LDL is just 30. And see the total vascular health. The total vascular health, there is no speck of cholesterol anywhere in the system. So I think vascular health, to a very large extent, depend on metabolic health. Shiv is here. I'm sure she will also be very happy to know that we need to have a look at it, that it is the oxidative stress on the metabolic health. And the second important thing is the vulnerability of sympathetic overdrive. I feel personally, after working for 46 years in cardiology now and bringing 54 books on cardiology, I feel that sympathetic overdrive and metabolic factors are very important to make a vulnerable and non-vulnerable to a vulnerable plaque. I'd like to have your comments on this. Thank you.
Very beautifully summarized, Dr. Chopra. There are a few important things which you really want to look at it here. For example, the stenosis, physiologic importance or hemodynamic importance of these lesions versus the plaque vulnerability and all. I think that is something when we are focusing on a therapeutic intervention for a patient, the patient comes to us and we look at it as to which plaque ideally need to intervene upon. Those will be the very important things, stenosis, anatomic, physiologic, and morphologic characterization of them. But when we are looking at the population, so you so beautifully put it that it should be all, the consideration should be the metabolic consideration there. And we really need to, I don't think we really need to start screening the people with the physiologic, anatomic, and morphologic ways and all. And do I really need to do CTs and all? No, I think I just need to physiologically normalize the metabolic health, improve the health. And as he was using one of the very important things, that the people who do not move, that was the, one point that he was pushing more and more on that day during 80% of the population, which was, or the audience, which was non-medical audience. So he was making that point again and again, that we really need to identify folks which need to be, or for that matter, should we just go with a sledgehammer approach here? Everybody just needs to do better. We need to maintain weight. We need to exercise. We need to eat better. And sugar and all, I think in the early days, we basically have to be very careful that first 2 years of life, at least we should do our best to avoid
All
sugar
residents listening for their families. A big round of applause to Dr. Narula. Aruni. Thank you.
consumption. लंबा कर दिया